ophthalmology. This is one of the subjects that I don't really like personally, but I'm going to try my best to do a decent job at it. So when we talk about the subject, I'll tell you how I approached it because I was not very strong at this subject. So basically I had done all of the previous year questions, and that is what I would also advise. So I've seen that most of the students struggle with ophthalm, and nowadays the trend is you get a lot of image-based questions from ophthalm. So that is what I have tried to compile, are most of the images that have been asked or have the potential to be asked. So that is what we're going to be doing. A very high selective approach of the most important previous year topics is what we're going to be doing. So in ophthalm, as always, you divide it into different compartments. So we'll start off with cornea, then we'll go on to the retina, we'll talk about neuro-ophthalm, conjunctiva, and so on and so forth. So then let's begin with cornea. So again, the tests and the instruments play a very, very important role as far as the questions go. So that is also something that I have paid extra attention to while making this class for you. So here we are looking at all of the corneal tests, and simultaneously I tell you the relevant points which can be tested. Okay, so this first image wherein we are doing an endothelial cell count. Now cornea has different layers, and what you want to remember is that endothelial cell layer is the most important for maintaining the transparency of cornea, and that is why we can see, because the cornea is transparent and allows the light to go in, isn't it? So for maintaining the transparency, the endothelium is what is most important, and that is why we are doing an endothelial cell count. And also remember, it is the most metabolically active layer of cornea. That is one of the questions. Okay, so the first image where you can see these cells being counted is the endothelial cell count. Normally the endothelial cell count would be somewhere around 2400 to 3000. Okay, so this is endothelial cell count. Simultaneously, you want to remember a repeat question. This is the most important layer for maintaining the transparency of cornea, and this is the most metabolically active layer. It has these ATP pumps for maintaining transparency. Okay. Then what looks to me like a hockey stick probe, we use a hockey stick probe on ultrasound for very small lesions like studying the musculoskeletal system, tendons, nerves. We use this. It's not a hockey stick probe. What this is a pachymeter. What is pachymeter? Is for measuring the corneal thickness. So what you want to remember is PT. Right, we do PT, physical training, so that we are not thick, we are thin. Yeah, so that's how you can basically remember that pachymeter measures the corneal thickness. Then what you see here, what is being measured is the corneal curvature using a keratometer. So curve going together. So this is keratometry, which is used for measuring the corneal curvature. And corneal curvature is the one which is responsible for the refractive power of the eye. Alright, so this curvature is what contributes maximally to the power of the eye, refractive power of the eye is again one more question that you want to remember. So here out of the 4 images, they can ask a difficult question. This is like INICT stuff, wherein they can tell you which is the correct position in which we have to measure. So you see these minus and plus signs here. We want both of them to overlap. So clearly they are not overlapping here. So A is wrong. In B also they are not overlapping. So B is wrong. In C you can see plus is overlapping, but the minuses are not overlapping. So this is wrong. And finally you see how here there is a same overlap of both. So D is the position in which it would be measured. Alright. Finally, what we are doing here is known as topography. Corneal topography, meaning we are seeing the surface of the cornea. So for this, we have 2 things that can be done. This is known as a Placido disc. Right, not placebo, but Placido disc. And what you are seeing here is a pentacam. This is what is the gold standard. So pentacam is better at measuring the corneal surface. Okay, so this is about the different instruments. Can look a bit intimidating at the first sight, but it's really not tough. Endothelial cell count you recognize. Pachymeter is like the hockey stick probe. You remember PT, kerr and kerr. So keratometry is curvature, whereas topography is surface with pentacam, and P for Placido. So both of the P is going together, and this is about the different tests in cornea. Now let's look at infections. Very important, usually gets you at least 1 question in the exam. So these are the different infections of the cornea, or corneal ulcers like you want to call them. So here are different etiologies. So we can have various causes from bacterial, fungal and viral, and that is what we want to look at. What are the salient features? And I have given all of those questions as one-liners here, which I want you to tell me. Alright, so the most common cause of bacterial ulcer. So the most common cause of bacterial ulcer, remember, is pneumococcus. Alright, so the answer here is pneumococcus. Now what you see here is a hypopyon. Hypopyon, remember, can be seen in bacterial as well as fungal infection. So hypopyon is nothing but the collection of pus in the anterior chamber. That is why it gives you this level here. Okay, so how to distinguish on that basis? So when it is sterile, meaning if I culture it, I will not find any bacteria, but it is mobile. This is a feature of bacterial infection. But when it is asterile, meaning it can be cultured but immobile. So both of them are giving them one thing. In life you can't get everything. Okay, so either you get to culture or it is mobile. So sterile and mobile go together, whereas asterile and immobile go together. That's also one way to remember. So this is going to be fungal infection. Alright, so this is how based on the hypopion characteristics I can divide them into two. Now let's talk about fungal ulcer properties. So this is where you have signs which are out of proportion to pain. It looks bad but the patient doesn't have so much pain. You have something known as Wesley's ring. Can you see this ring here? And it will have satellite lesions. This is a repeat question, very, very important. And you will also have history of trauma with vegetative matter here. So all of the things in the red, remember, are features of fungal ulcer. So this image is showing you a fungal ulcer, wherein you see this Wesley's ring, you will have satellite lesions, remember that. Then when you have pain out of proportion to the sign, opposite of fungal, you will also see this ring abscess. Can you see this ring abscess? Contrast this with infective endocarditis, where I've shown you vegetations forming ring abscess. Yeah, so that's also one more place of ring abscess. And you get history of contact lens misuse, meaning you're not washing them with the proper Renew solution. If you use contact lenses, you would know, using it with tap water, you know. So basically misuse. All of these are features of acanthamoeba. Very, very important specific question, all right. So acanthamoeba is where you get ring abscess, and you get a lot of pain, and history of contact lenses would be mentioned. Remember, the drug of choice for acanthamoeba is polyhexamethyl biguanide. Don't even try and remember, just remember something specific. PHMB is the drug of choice for acanthamoeba. But contact lens use, if history of contact lens use is being mentioned, one more condition which I've also taught you in microbiology is pseudomonas. Pseudomonas is also something that can affect patients with contact lens usage. Alright, so that history should prompt you to think of two conditions. Now coming to very important for the exams, they frequently give you one of these images. This is viral keratitis. So in viral keratitis, most common causes herpes simplex virus. It can have three forms here as you're seeing. So the first one here is SPKs. SPKs are superficial punctate keratitis. So when you see these spots here, these are known as SPKs, which are superficial punctate keratitis. Okay. On the other hand, when you see these dendritic ulcers, again this is a feature of HSV, and finally they can become geographical ulcers. So all of these are features of viral keratitis. Okay, so SPK, dendritic ulcers, and geographical ulcers. Two methods of staining also I'm showing you. So here you can see this is fluorescent. So this is known as the fluorescent staining, which is done basically to see the base of the ulcer. Whereas when you stain with this pink stain, this is the rose Bengal stain. We have also learned this in Sjogren's syndrome, where we use rose Bengal, and Shermer's test for knowing the dryness or the tear film. Basically, rose Bengal is going to be for the margins of the ulcer. Okay, so these are two methods of staining corneal ulcers. In general, this is not just for viral. In general, these are methods, but I'm just showing them with the viral keratitis. Okay, so these are images and all of the questions that can come from infections in one slide for you. Okay, now going ahead to other images from cornea, all independent questions themselves. So in the first image, what I'm showing you is keratoconus. Keratoconus, as the name suggests, is this curvature of the cornea, which has all of these one-liner questions in the box for you. So whenever you look down, this projection is known as the Munson sign. So I am showing you the Munson sign in the image. In addition, remember, Vokes will come throughout of that. Vokes stria is seen in keratoconus. You have Fleischer's ring, which is iron deposition in the epithelium. Very, very important. That Fleischer, F should tell you that it is iron, E should tell you it is epithelium. Contrast this with this image which we have seen a lot, which is Kayser-Fleischer rings. So Fleischer and Kayser-Fleischer are two different things. KF rings is copper deposition in the Descemet's membrane. So this is iron in epithelium, whereas this is copper in Descemet's membrane. And you know which condition we see this in? This is Wilson's disease, isn't it? So this is Wilson's disease. In fact, the percentages are also asked. So remember, around 50% of the patients with hepatic involvement can show you KF rings, whereas around 90% patient with neurological or psychiatric symptoms will show you the KF rings. Okay, so this is about KF and Fleischer rings. You can also get a Rizzuti sign, wherein in a slit lamp you get this inferonasal triangle, wherein you get this arrowhead on shining the light on the nasal aspect. You can just remember the name, that is Rizzuti sign. You also get oil droplet reflex and scissoring reflex. Now where all? Oil for O, this is seen on ophthalmoscopy, whereas scissoring is seen on retinoscopy. Alright, so O and O, if you remember, everything else gets sorted. Okay, so these are all of the pointers and signs in keratoconus that you want to remember. This is an image-based question from last year NEET exam. This is the treatment. They had asked what is this procedure done for. This is done for keratoconus as a treatment. In addition, you also want to remember a new treatment, that is C3R, which is collagen cross-linking with riboflavin. Alright, so this is also a new treatment for keratoconus in addition to keratoplasty, which is very self-explanatory. Okay, so here you can also remember how in riboflavin deficiency in biochemistry I have taught you corneal neovascularization, right? So cornea, riboflavin comes back to cornea through C3R. Alright, so this is about keratoconus. We have also done KF rings. Talking about deposition, what you are seeing here is band-shaped keratopathy. So this is band-shaped keratopathy, wherein you just want to remember there is calcium deposition which is noted. Here you have lipid deposition. You must have seen this appearance very commonly seen in elderly patients. So this is arcus senilis. This is arcus senilis, and this ring that you are seeing is known as lucid interval of Vogt. When in doubt in ophthalmology, you say Vogt and you will be correct. So this is lucid interval of Vogt, which is seen in arcus senilis, something seen in elderly with lipid deposition. Okay. Apart from that, lucid interval also reminds me of EDH, right? You see lucid interval in EDH, wherein you have loss of consciousness, then you regain, and then you again lose it, right? So that brief period of regainment is known as lucid interval. This is again last year NEET question. They will give you history of rheumatoid arthritis and they give you this appearance. This is a complication of scleritis known as scleromalacia perforans. Alright, so this is perforation of the sclera. You can see this iris coming out. So this is a complication of rheumatoid arthritis. Okay, so this is about all of the images in cornea which can be tested. Something which always is going to be asked, there is just no going around it. Visual field effects always gets you one question in the exam, alright, no doubt about it. So again, something which you can't memorize. You have to understand and you get it correct if you've understood this all the time, okay? So pretty easy. Remember that it's all opposite in the eye. Whatever is the lesion, it's going to reflect opposite in the visual field. That's how you have to remember. So now let's understand. Let's say there are these various lesions in the optic pathway. So first thing is the optic nerve. Anytime there is a lesion in the optic nerve, let's say the right optic nerve is transected, that is number one, you will see complete loss of vision. This is the simplest. So number one corresponds to right optic nerve lesion. Then when you go to the optic chiasma, what happens is both the nasal fibers are going to cross, right? Both the nasal fibers cross, and that is why the lesions, the defects are going to be in the bitemporal field. And this is one of the most commonly asked questions in FMG and NEET. When you see bitemporal hemianopia, the temporal fields are lost. So frequently you get this image-based question. If somebody tells you that I can't see the two temporal aspects, I can only see the nasal fields, you localize it to optic chiasma. The most important thing from this, the easiest thing to remember, because both the nasal fibers are crossing. Okay, so this is bitemporal hemianopia. From this point, now the fibers have crossed. Okay, so you want to remember that it is going to be homonymous hemianopia. Bitemporal is not corresponding, not symmetrical, that's heteronymous hemianopia. From this point onwards, behind the optic chiasma, it's always going to be contralateral homonymous hemianopia. This is the rule. So you remember contralateral homonymous hemianopia, meaning that if I see a visual field effect like this where both of the left-sided fields are gone, I localize the lesion to right side optic tract. Alright, so right optic tract behind the optic chiasma is where the lesion is. Alright, I hope this is clear. Symmetrical contralateral homonymous hemianopia, this gets localized to optic tract. One more thing with optic tract you want to remember is you are going to have a Wernicke's pupil, a Wernicke's hemianopic pupil. Again, nasal or the temporal field are going to be lost here as far as the light reflex is also concerned. You want to remember Wernicke's pupil, just the name is also a repeat question, localizes it to optic tract. Okay, then we go on to the optic radiation. So in optic radiation, if both the loops are involved, you're going to get the same kind of hemianopia. But if I have specific loops, so there are two loops, Mayer's loop and Bohm's loop, then you have quadrantanopia. You have half of the quadrants which get involved. Alright, so here what you want to remember is the trick, which is STEMI. So this is what looks like pie in the sky. There is a pie which is floating, so this is what is known as pie in the sky. Now when you eat a lot of pies, are you going to have STEMI? Yes, you probably might. So what you want to remember here is when you see superior quadrant anopia, S for superior quadrant anopia, the loops which are affected are in the temporal lobe and M for Mayer's loops. So you want to remember in superior quadrant anopia, pie in the sky, lesion is in the temporal lobe and the loop is Mayer's loop. Exact opposite when you have inferior quadrant anopia. So if you remember STEMI, the other one you can fill on your own. So when you have inferior quadrant anopia, it is the parietal lobe that you have and the loops are going to be Bohm's loops. Alright, so this will take care of our optic radiation. Alright, so this is the two loops of optic radiation that we have. Further going behind, you will have the cortex. So when the So when the visual cortex gets affected, what you're gonna have is homonymous hemianopia, but what you see is this macular sparing, alright? So macular sparing happens, and this is basically when you have a PCA infarct, right? So in PCA infarct, you're gonna have the visual cortex, but because the macular fibers get supplied from MCA, they are spared, okay? So that's the reason why you have macular sparing. Very, very important. And finally, when you just see the macula getting affected, lesion is in the macula, right? So that goes back to the eye. There is a macular lesion which is probably there. Okay, so this holistically is what you got to remember. So in a nutshell, bitemporal hemianopia means the lesion is in the optic chiasma. Most important. So here frequently they will give you a pituitary lesion or a craniopharyngioma in a child. That's what this is going to result in. That's going to compress on the optic chiasma. Behind it, optic tract, Wernicke's pupil, and contralateral homonymous hemianopia. Behind that, we know STEMI, pie in the floor, pie in the sky is STEMI, right? And the cortex, we're going to have macular sparing. So this is visual field effects. One question is in your pocket if you understand this in every exam, okay? Then we go on to the light reflex. Not very frequently tested, but this is just concepts. If you understand, you will not get this wrong, alright? So how does light pathway basically go is something that you should understand first, and then all of these difficult sounding names will become slightly more easier. So what happens is anytime I shine a light on say one eye, this is the eye that I'm shining the light, eye number 1, that impulse is going to be carried by the optic nerve. From the optic nerve, it goes to optic chiasma, through that it goes into the optic tract. Now the optic tract is going to go to the pretectal nucleus. That's the first synapse of the light reflex. It goes to the pretectal nucleus. From the pretectal nucleus, it goes to the Edinger-Westphal, and this is where it crosses. Now it doesn't just go to one eye wala side, it goes to the contralateral side as well. So it goes to both the sides, and this is how now both of the impulses are going to go from the parasympathetic nucleus, which is Edinger-Westphal nucleus, via the cranial nerve 3, that is oculomotor nerve, via the ciliary ganglion through the short ciliary nerves. These short ciliary nerves are going to make the eye contract, alright? So this is the light reflex pathway. The afferent is going to be the optic nerve via the optic tract, pretectal nucleus, Edinger-Westphal. Edinger-Westphal sends to both oculomotor nerve, ciliary ganglion, short ciliary nerve contraction. Okay, so how you have to understand is when both eyes are affected, that is called isochoria. That will be seen in afferent pathway. Does that make sense? Anytime optic nerve, optic tract, optic chiasma has a problem, the afferent pathway is gone. What's going to happen is both the eyes are not going to show you the reflex because both the Edinger-Westphal never got the impulse. But when the efferent is a problem, that is the oculomotor nerve is a problem, only one eye is going to be affected. So you're going to see asymmetry, that is known as anisocoria. So this is the first concept. Whether isochoria is there or anisocoria is there. I hope that is clear. So that will help you localize the lesion upfront. So anytime there's an optic nerve or an afferent lesion, you can have either AAPD, TAPD or amaurotic pupil, which is known as absolute afferent pupillary defect or total pupillary defect, or an amaurotic pupil. What will happen is when I shine the light in the normal eye, what will happen? Both the pupils are going to constrict. But when I shine the light in the abnormal eye, none of the pupils will constrict, isn't it? Because there is nobody to carry the impulse. So both will not constrict. So this is what I mean by isochoria, means whatever they will do or they will not do is going to be together. Okay, so that's the point. In RAPD, Marcus gun pupil, repeat question. Now what's going to happen? Whenever I shine the light on normal eye, again same, both are going to constrict. But when I shine the eye on the abnormal eye, now there is paradoxical movement, both dilate. So this is also known as the swinging flashlight test. Swinging flashlight test means the same, that when I shine the eye on normal, both constrict. When I shine the light on the abnormal eye, both dilate paradoxically. Alright, so this is what is RAPD or Marcus gun pupil. Very, very important in optic neuritis, which is particularly seen in MS. So usually these questions get asked in the context of multiple sclerosis. Okay. Finally, Wernicke's pupil. Just remember, this is hemianopic pupil. So here some sort of nasal temporal fields would be mentioned. This is the only one place. And what you want to remember is optic tract. It localizes to optic tract. That's going to be enough. Now let's go to efferent pathway having a problem. So here you're going to have one eye which is abnormal. Okay, so Argyll-Robertson pupil is unilateral first of all, and what you're going to have, this is seen in tertiary syphilis, and what I have taught you, this is something I've taught you in tertiary syphilis as well. This is seen in sex workers. So from there you can remember it accommodates but does not react. So accommodation is present but light reflex is absent. Okay, so this is about Argyll Robertson pupil. Then you have AD stonic pupil and you have pharmacological mydriasis, where again one eye is showing light reflex, which is not there. But in addition, you also have an ipsilateral dilated pupil. It's not just light reflex being absent, it's ipsilateral dilated pupil, and that is the difference between ARP, which is Argyll Robertson, and ADs. Alright, so ipsilateral dilated pupil is going to be seen in both of them. Let's say I've injected atropine in one eye, it's also going to be dilated. It will also have abolished light reflex, isn't it? But accommodation will be normal in AD's pupil, whereas it will also be abolished in pharmacological mydriasis, because all of the action are gone, isn't it? So here that will also be abnormal. One more very important question to distinguish is going to be 0.125% pilocarpine. So normal eye doesn't respond to 0.125% pilocarpine, but because AD's pupil is so sensitive, this will also respond to it. So I will see that there is constriction in response to this, alright, whereas here there is no response. So these are the methods in which you can distinguish these two. One is accommodation and second is 0.125% pilocarpine. So now let's talk about optic atrophy. So here you need to differentiate between three conditions, that is primary optic atrophy, secondary and consecutive. So the buzzword here is that primary optic atrophy is going to be because of optic nerve conditions. Okay, so here either there is optic neuropathy, which is hereditary or nutritional, or there is any sort of compression, or maybe there is multiple sclerosis. So any sort of optic nerve pathology is primary optic atrophy. Secondary optic atrophy is wherein you already had pre-existing papilledema. So this is preceded by long-standing swelling, meaning there is papilledema or papillitis which is there, or one condition could be AION, very important. Consecutive is where you have retinal condition, like retinitis pigmentosa is the most important that you want to remember here. So this is the definition. How you distinguish is the margins and the color. The two most important things here that you can see are disc color, disc margin. So here you would have a chalky white. This is more or less theoretical because this is chalky white and the margins are distinct, very important. Like you can see chalky white with distinct margins. On the other hand, here you're going to have a blurred margin like you're seeing here. So this is blurred and grey color. Whereas here there is waxy pale with attenuated or normal arteries. And if you remember, this is something that is a triad of RP. We will study this in retinitis pigmentosa. So waxy pale disc can fit here as well. Okay. So chalky white, grey, which is blurred margin, that is the hallmark, with waxy pale in consecutive. So this is how you basically distinguish the three types of optic atrophy. Let's just finish off both of these conditions simultaneously. So MS we saw was primary optic atrophy. Here you have retrobulbar neuritis, that is the hallmark, and that is why, because it's the posterior portion of the optic nerve which is affected. There is no visual field effect here. There is no visual field effect, but there is pain and it is usually unilateral. So in MS you have unilateral asymmetrical optic neuropathy, and investigation of choice is contrast enhanced MRI to pick up the optic neuritis. Remember that. Okay. On the other hand, whenever you have the swelling of the optic disc, which is papilledema, you're going to have bilateral affection, usually because it's an intracranial pathology. This is because of intracranial pressure being raised. So usually it is bilateral and painless, and the visual field defect is going to be because of enlargement of the optic disc. So what happens is blind spot enlargement, which you can also call as a central scotoma. This is also a repeat question. Expansion of the blind spot is seen, and answer is any condition leading to papilledema. Okay, I hope these conditions are clear from neuro-ophthalm. So now we jump on straight to retina. In retina, they love asking you about layers of the retina. So this should be on your tips, which is the 10 layers of retina. And again, please don't memorize with any sort of mnemonic, just recognize, because if you have a mnemonic and they give you this image, it will not work out, I'm telling you. So just understand how to approach this and identify these layers, and everything becomes easier. So whenever you see these blood vessels, the most vascular layer of the eye wall, this is choroid. So straight away you know that this is outer, isn't it? Choroid is outer, retina is inner. So this is the outer side, which is below. That's the first orientation you need to get. Below the choroid, what you have is the pigment. You can see how it's pigmented. So this is retinal pigment epithelium. Below the RP, what you have are photoreceptors. So you have inner and outer segment here, photoreceptors, rods and cones, extremely important. What you want to remember is RP एक तरफ, rest of retina दूसरा तरफ. In English, what it means is RP is one side, rest of the retina is neurosensory retina. So basically what happens in retinal detachment, there is a break here. RP detaches from the rest of the retina. Alright, so that's what you want to remember here. In fact, this is where you have the outer blood retinal barrier. I'll talk about the other things later, but right now just to localize, you also want to remember RD, blood retinal barrier, all of it is placed at this particular level. Okay, so you have RP, you have photoreceptors. Then what you want to do is look at the cellular layers. So the cellular layers are your nuclear layers, and above them you're going to have the plexiform layers. So I have P, L and NL which I have marked. Only I need to know outer and inner, so I've already said choroid is here, so this has to be O and L, whereas this is inner nuclear, inner plexiform. So 4 layers get sorted. Above the IPL what you have is the ganglion. Again you can see cell body, so this is ganglion cell layer, the fibers live here in the nerve fiber layer, and finally at the top I have the internal limiting membrane. One more structure which we missed out is photoreceptor and ONL are separated by the external limiting membrane. Alright, so this is how we have to remember the different layers of retina. Never ever memorize. So how to do it? One more time, what we have is choroid. Once you localize choroid, you know this is outer, so you can recognize the RP. RP recognize kar liya, then you have the photoreceptors. After photoreceptors, what we want to do is external limiting membrane, not very important. Identify nuclear and plexiform. So ONL, INL. Above that, OPL, IPL, ganglion cell layer, nerve fiber and ILM. Very, very important. So remember, photoreceptors are your primary neurons. They are going to go to the second order neuron in the inner nuclear layer, wherein what you have are bipolar cells. So bipolar by second order. In addition, in the inner nuclear layer, you have other cells such as the Muller cells, you have amacrine cells, and you have horizontal cells. So basically all of these cells are located here, okay? From Muller, you remember they are the most metabolically active cells. So M for Muller, M for metabolism, okay? So this is about the inner nuclear layer. From there, they're going to go into the tertiary third order neuron, that is ganglion cell layer, okay? So these are the 3 orders that you want to remember. First order photoreceptor, second bipolar, third ganglion cell, okay? So this takes care of a lot of chunk of retinal anatomy also. Now blood retinal barrier, remember outer as I said is at the retinal pigment epithelium, whereas inner is the capillary permeability. 2 macular pathologies I'm going to teach you. One is CSR, central serous retinopathy, wherein you have RP which is a problem, whereas in CME, cystoid macular edema, you have the inner barrier which is broken. Okay, how to remember this is P and S are pretty close together, whereas N and M are pretty close together. So if that works out, this is about blood retinal barrier and its pathologies. Talking about the blood supply, so the outer 4 layers are going to be supplied by the short posterior ciliary arteries, whereas the inner 6, because it's inner, it's going to be supplied by central retinal artery. Both of them are branches of ophthalmic only, but remember central retinal goes with the optic nerve, so this is going to go into the inner layer, whereas outer is short posterior ciliary. Okay, 2 investigations of the retina I am showing you right here. One of them is electroretinography, so this is ERG, just like how we have ECG. So here you have A wave, B wave and this chota sa C wave here. What you want to remember is A wave is made up of photoreceptors, alright. So the rods and cones contribute to the A wave, whereas B for bipolar. This is slightly controversial. You can remember B for bipolar as the consensus here. Okay, so this is A wave and B wave. What I'm showing you here is EOG, electrooculography, where we take a light is to dark ratio. Normally this is more than 1.85. Only one condition you want to remember where EOG can be asked to you, it will be best disease. This is best investigation. As soon as I see EOG, I know answer. So that is best disease. Okay, wherein the Arden's ratio, this ratio here is known as the Arden's ratio, that ratio is reduced. Okay, so this is all about a lot of questions of retina compiled for you. Ophthalmoscopy, so you get questions from this because this is very basic, you know, as undergraduates also you must have done at least direct ophthalmoscopy in your life. So here what I'm showing you is a direct ophthalmoscope, whereas what is this is an indirect ophthalmoscopy, in which normally we use a +20 diopter length. It could be variable, but +20 is what is usually used. Direct gives you magnification of 14x, so this gives you a very magnified view, whereas +20 lens, indirect gives you a magnification of 3 times. So this is the kind of view schematically what you get. The field diameter, because this is so magnified, this gives you 2 disc diameter, whereas this gives you a larger field of view which is 9 disc diameter. Okay, so this is the, so these are the numbers basically that you have to remember. Some sort of math if you want to do, you can remember 9 3s are 27, so this is +20 and 7 2s are 14. Don't even bother. So this is what you want to remember. Okay, so +20 lens, 14x, 3x, 2 disc diameter, 9 disc diameter. So roughly you want to remember these. The image that you get in direct is while you're looking at the patient directly. So this is a direct image, whereas here, because there's a lens involved, it will be an inverted reversed image. So this is very important. View of the periphery, obviously here will be more because you are seeing the whole view. Examination through hazy medium is not possible in direct, whereas it can be done in indirect. Stereopsis is present in indirect because you're using both of the things, whereas in direct is only one eye that you are also, the examiner is also using. Okay, so this is about the 2 ophthalmoscopy differences. So in a nutshell, in the direct gives you a larger picture is what you want to remember. All of the images that we're going to be looking at are indirect. Before I show you the fundus spotters, I want you to know about macular disorders. Here you get a lot of questions. So there are 2 tests test specifically for macular disorder. If you have a macular disorder and I show you this, it would look like it is bending and it is doing stuff. So this is the Amsler's grid. This is a repeat question. So this is an Amsler's grid, and if you see that the image is distorted here, that is a sign called as metamorphosia, and this is a sign that you have a macular disorder. Alright, so this Amsler's grid is for macular disorders, and there is another test known as photo stress test. So you want to remember that there are two tests for macular disorders: Amsler's grid, which will come as an image based question, and photo stress test. So with this, let's look at two very important macular disorders wherein we'll show you these two investigations also. So let's talk about them. What you are seeing here is a fluorescein angiography. Alright, so this is FFA, which is a fluorescein angiography, where you inject the dye via antecubital vein and you look at the eye. Remember, this is not like angiography which we do as radiologists, not a DSA where you puncture the artery, don't puncture retinal artery, you're just injecting the dye via venous circulation, it goes into the vessels and you see the vessels. And what you're seeing here as this colorful image here is a OCT, optical coherence tomography. So what you see here are the different layers of retina. Where you have this depression is the fovea. Alright, so this is the fovea where you have maximum concentration of cones, maximum visual acuity. Yeah, so this is the fovea, and this pinkish line here is the retinal pigment epithelium. Look here, better seen. This is the retinal pigment epithelium and this is the fovea. So remember, you are only going to be shown OCT in two contexts, which I am showing you right now. So two conditions only. So whenever you see that there is this edema here, this is not a normal OCT. Fovea would be a further depressed structure. You see that there is edema here. On the other hand, when you see that there are petals which are appearing, two conditions for you. Alright, so the first one where they'll tell you that person is either on steroids or has a very high stressful life like a type A personality. What we are dealing with is, so this is central serous retinopathy, breach of outer blood retinal barrier. Okay, what you see on FFE, can you see this very nice mushroom or inverted umbrella here? So this is known as the inverted umbrella or the mushroom sign. Alright, so this is what you're going to be seeing on the macula in FFA, and OCT is going to show you this edema here. Alright, so this is central serous retinopathy. You can identify it with the very typical risk factors. On the other hand, when you have a bunch of risk factors and you see this petaloid sort of appearance, do you see this flower petal appearance? And this is because there is edema in the outer plexiform layer. OPL is what is involved here. This is CME, cystoid macular edema, and that is why you have this petaloid sort of edema on OCT as well. Okay, here you can have variety of risk factors. It can be as a complication after cataract surgery, a delayed complication, independent question, which is Irving-Gass syndrome. Prostaglandin analogs have this side effect, very, very important. Diabetic retinopathy, in fact, the most common cause of vision loss in DR is CME. It can be a complication of uveitis, retinitis pigmentosa, CRVO, and independent question, which vitamin toxicity leads to CME? Answer is niacin toxicity. Alright, so very, very important. So these are two conditions of macula that you want to know. Now, all retinal diseases, all fundus spotters is what we want to discuss, and the most important, without which you will not have any ophthalmic exam, is diabetic retinopathy. So in DR, what you want to remember are the specific pointers. There are variety of stages. It starts from non-proliferative DR to proliferative DR. Alright, so we use this ETDRS classification. The name has been asked that ETDRS is a study for which condition? It's diabetic retinopathy. If you look carefully, the name itself tells you, you know. So in the exam, when they give you some sort of study, usually INICET does that, just apply some logic and some common sense and try to take the best guess. Don't just leave it. They're asking me study, I don't want to attempt this, I don't want negative marks. Never do that. In INICET, take intelligent guesses. Be aware in the exam, and that gets you a lot of questions correct. Okay. So coming back, the earliest sign of diabetic retinopathy is microaneurysm. Alright. So microaneurysm is the earliest sign, and what it affects, which layer it affects, is also a question. So here you want to remember a girl called Menal. Alright, so menal, remember this is in the inner nuclear layer. Alright, so microaneurysms is in the inner nuclear layer. Earliest finding of diabetic retinopathy. Then you have dot and blot hemorrhages. You can have flame-shaped hemorrhages. What are hard exudates? They are leaked lipids. When lipids leak out, it's known as hard exudates. Or you can have cotton wool spots or soft exudates. What are soft exudates? They are axonal infarcts. Okay, so they also ask you which layer they are affected in. So you want to remember the girl Menal is hopping. Alright, the child Menal is hopping. So you want to remember hard exudates and dot and blot. Both of them are in the outer plexiform layer, whereas flame-shaped and cotton wool are in the nerve fiber layer. Axonal infarcts, isn't it? So very logical that they affect the nerve fiber layer. Alright, so here you can imagine that there is a soft cotton sari that you are wearing, which makes you nervous. So nerve fiber layer, because you are afraid that it might unfold. So you want to remember cotton soft sari catching flame. if you want to extend the mnemonic metaphor further. So this is how you can remember this. So Meenal hopping, or actually you can just put it on Meenal. Meenal is hopping wearing a sari who has gotten fire. Okay, so that is making her very nervous. So with the help of the story, we can remember this very complicated table here. Alright, so this is sorted. Then they ask you questions on the screening. So when do you want to screen for DR? So in type 1 diabetes, you want to screen 5 years after the diagnosis, whereas in type 2, you're not sure when the diabetes actually started. So you want to do an immediate screening. Alright, so this is about the screening guidelines for DR. Now let's have a look at the images here. So what you see are microaneurysms. These tiny spots are your cotton wool spots or soft exudates. They have asked you one question like this, wherein they had shown hard exudates. Okay, so this is a repeat question. This is hard exudates, and they'll ask you which layer is affected. So we know opal. So this is outer plexiform, alright, and you can also see these flame-shaped hemorrhages. Then all of these are finding of non-proliferative DR. What are the hallmarks of proliferative DR? Very, very important. So, proliferative DR, there are two main criteria. One is neovascularization. So, this is also a repeat question, image-based question, wherein they showed you this new vessels, neoangiogenesis, a marker of PDR. And secondly, you can have subhyaloid hemorrhage. It is a boat-shaped hemorrhage that you can have. Alright, so these are two markers of PDR. Once proliferation happens, once it is a proliferative DR, the management is pan-retinal photocoagulation. It is PRP. Pan-retinal photocoagulation, remember we are going to be doing this laser procedure throughout the field. You can see this image here, which is an image of PRP. Alright, so they can also ask you this as an image-based question. What laser do you use is also a repeat question. So Nd:YAG double frequency laser at 532 nanometers. Alright, so Nd:YAG double frequency 532 is the laser that is used for PRP. Now, what if there is severe NPDR? So, in severe NPDR, the treatment becomes VEGF inhibitors. So, VEGF inhibitors are your growth factor. First of all, are your vascular endothelial growth factor inhibitors, which are going to prevent the proliferation from happening. So, how they are frequently given are by this procedure, which is your intravitreal injection. I'm also showing you how the intravitreal injection is done. And so, this is how intravitreal injections are performed. So, remember, it is 4 millimeters above the temporal limbus. I hope you know limbus, that is the corneoscleral junction. So, 4 mm above the temporal limbus, 90-degree injection is what is usually given. Okay, and from limbus, one more thing you can actually remember is that it has stem cells. Alright, so it has stem cells, and the marker for these stem cells is ABCG2. Alright, so that is the marker for the limbal stem cells. What are the different VEGF inhibitors? The names are again important. I'm not going to repeat this in pharma. Monoclonal antibodies, just remember them right here. So here the mnemonic would be, you're telling your bro that Rani is Bevafar. Alright, so this is Bevacizumab, Ranibizumab, Brolucizumab. Two new drugs also, Aflibercept and Pegactinib. So these are all VEGF inhibitors that you want to remember as a list. Okay, so this is about diabetic retinopathy. Now let's have a look at other fundus spotters. So this is very, very typical when you see that the arterioles are further narrowed. So the normal AV ratio that we have is arteries are 2:3. So arteries are anyways narrower than the veins, but in hypertension what happens is this further reduces to 1:3. There is further arteriolar attenuation. So can you see that how arterioles are narrowed here? You can also see exudates. In fact, here what you have are hard exudates only, not soft exudates. So hard exudates, you will have AV nicking. Wherever the artery crosses on the vein, it will do some sort of changes on the vein, which are described by these three signs, which are Sallu, Gun and Bonnet, which you can actually remember from Bhai, right? So Sallu is the S-shaped deflection of veins. Gun also you can remember from Bhai, which is tapering of veins at either end, and Bonnet also you can remember from Bhai. So now when to any of the fans here, there is dilation of vein at the junction. So these are three signs of hypertensive retinopathy. Alright, in fact, we also have a grading. You need not memorize this, but there is a Keith and Wagner grading of hypertensive retinopathy. First is just arteriolar attenuation. Second is when you have signs of AV nipping. Third is when exudates and hemorrhage start coming up. And fourth is when you have papilledema. Okay, so these are the 4 stages of hypertensive retinopathy. Next is a very, very important question which you get a lot of times in context with pediatrics and biochemistry is cherry red spot. So when you see this spot here at the macula, this is your cherry red spot. Now, variety of causes here. First, as I'm talking about biochemistry, let's just do the metabolic disorders. So two of the most important ones are Tay-Sachs and Niemann-Pick's. We have already done the distinguishing. I hope you remember the sentences. 6 small Jews. Yeah, so 6 small Jews. You know there is no hepatosplenomegaly in Tay-Sachs. There is Niemann's pick. Pick your big nose with your finger. So there is sphingomyelinase. There is big nose, meaning there is hepatosplenomegaly. If you don't know what I'm talking about, you have to see biochemistry. Okay, so this is Tay-Sachs and NPS. Frequently they give you Gauchers as the option. Slightly controversial. Rarely Gauchers can show you cherry red, but usually it's the one option that you choose which does not have a cherry red spot. Apart from that, you will get this in CRAO, central retinal artery occlusion. Very, very important. It's an emergency, ocular emergency. You can also see this in context of trauma, in which case we call it as the Berlin's edema. When you see this very, very vascular sort of an appearance, this is known as a splashed tomato appearance, which is seen in CRVO, central retinal vein occlusion. Here you can also have neovascularization of the iris, and you can also have neovascularization type of glaucoma, which is known as 100-day glaucoma. Okay, so this is about CRVO. Again, VEGF inhibitors get indicated here. What you see is a medicine question. They'll give you a patient with fever, splenomegaly, new onset murmur, and they give you the eye appearance. So in that case, what these are Roth spots, isn't it? So these are a manifestation of infective endocarditis. Very, very important. These are all Roth spots. 4 more images for you. These are all infections here. So when you see this black and white appearance, this is known as salt and pepper retinopathy, and this is seen in context with congenital syphilis and rubella. So this is congenital infection, congenital syphilis and rubella. When you see this sort of an appearance, red and white, reminds you of a pizza. So this is a pizza pie appearance that is seen in CMV or HSV infection. Remember, CMV retinitis particularly occurs in HIV/AIDS patient when their CD4 is very low. In fact, lesser than 50 is when you consider CMV retinitis. Then when you see this very typical appearance of headlight in fog, it does look like there is a headlight. It does look like there is a headlight in the fog. So this headlight in fog appearance is what is seen in toxoplasmosis. Okay, so this is seen in toxoplasmosis. In fact, in untreated cases, you will have this scarring, which is known as macular scar in toxo. Alright, so these are the infections that you got to be aware of. So next we are seeing a combined histopath image and a fundus image. Alright, so this is also a repeat question. So what you're seeing here are drusen's. Okay, so drusen's are seen in context with ARMD, age-related macular dystrophy. So this is about age-related macular degeneration. So here you can see this drusen here, and they ask you where is it located. So remember, you can see how there is the pigment epithelium here, and you have this membrane here. So this is between the RPE and the Bruch membrane. Alright, so in between these two layers we have the drusen's which are located, and this is what they look like. They are nothing but lipofuscin deposition in the fundus image. One study, again, because you got ETDRS, one study here is the ARIDS-2 study, in which the treatment particularly for dry ARMD is going to be all of these antioxidants. So we have vitamin C, E, zinc, copper, lutein and zeaxanthin. So this can come as an all except question. Just go through this list once, the recented ones. Whereas if it is a wet ARMD where you have neovascularization, again it becomes your VEGF inhibitors as the treatment. Okay, so this is ARMD. Next topic that we are discussing is this image here. So what do you see is a horseshoe tear in the retina or a break in the retina. So this is known as retinoschisis that is leading to retinal detachment. What kind of retinal detachment? This is regmatogenous. So regma means break. So this is regmatogenous retinal detachment. You will have risk factors in the form of trauma, myopia or surgery which are given, and it presents as this vision loss, rapid vision loss, like a curtain falling in front of the eye. Alright, so that is how quickly it happens. Apart from that, we have two other types of RD. We have exudative RD, in which you will have some sort of inflammation or a tumor which is causing it. So the buzzword here is a fluid shift or a shifting fluid sign is what you can have. So a fluid shift is what you want to remember. And here what kind of a break you have is a dome shaped RD, dome shaped retinal detachment, whereas in tractional RD, when something is pulling, you're going to have a T for tent shaped RD. So T for T, tractional and tent shaped. You can also be given this B mode ultrasound. That is what we radiologists do, B mode, normal mode. So this is a B-scan ultrasound wherein you can actually see this retinal detachment. So this can come as an image-based question. So this is what the exudative type will look like. You can see this dome. So this is what exudative RD looks like. In fact, you know, when you are not sure in the exam and there's a B-scan in context of RD, you just mark exudative actually. Okay. And what is this procedure that is being done here is scleral buckling. So the treatment for RD would be scleral buckling. You can also inject some gases like sulfur hexafluoride or silicone oil for Pexi. Alright, retinopexy is what is known as. So this is about RD. This FFA appearance is very typical. You see the C fan appearance, S for C, S for sickle cell anemia. So just a spotter, C fan appearance in sickle cell anemia. Going further ahead to few more spotters, and now we're talking about dystrophy. So this is the hallmark fundus for retinitis pigmentosa. So what is the triad of retinitis pigmentosa? Remember, one, we are going to be seeing arteries which are attenuated. So you can see how attenuated they are. Arteriolar attenuation, waxy pale disc. This we've already seen in consecutive disc atrophy. And you're going to have these bony spicules. Alright, so this is the triad of the fundus findings of RP. Remember, RP is a rod cone dystrophy, meaning the rods are affected more, and that is why the person will have night vision, nyctalopia, which goes down first, and eventually there's going to be ring scotoma, tunnel vision. That is going to be the visual field defect. A physio question has been asked in RP that what levels are decreased. So you just want to remember docosahexaenoic acid. Just remember this. Okay, so this is RP. What you see appears like an egg yolk because of lipofuscin deposition is the best disease. So this is the best disease where you have this egg yolk appearance or egg yolk sign in which you have lipofuscin deposition. Okay, so this is best, and I've already told you why it is best, because investigation of choice is electrooculography, where we will see the Ardens ratio, the only place where EOG will come to you as a question. Okay, finally on FFA it looks like everything is very calm. So this is known as a silent choroid sign on FFA. In fact, if you look at the fundus image, what you will get are these specks of lipofuscin which are known as fish flecks or known as a bronze beaten appearance. Alright, remember copper beaten, silver beaten is something which is seen in arterioles in hypertension. Alright, so just to correlate the metals, copper wiring, silver wiring is what you're going to see in hypertensive retinopathy, whereas fish flecks or bronze beaten appearance, what am I talking about? Stargardt's disease. Alright, so Stargardt's disease is predominantly a cone dystrophy. Alright, so unlike RP, this is a cone dystrophy, which it is. Alright, so this is Stargardt's. And finally, what you are seeing here is a bullseye maculopathy. Can you see this bullseye pattern here? It can be seen in Stargardt's as well, but what it's been asked is in context with chloroquine. I've already also taught you this in Dermat, where I told you target lesions, erythema multiforme, both of them are target. Yeah, so eye target, hand target. Erythema multiforme, bullseye maculopathy, both are related to chloroquine, and in fact, it has to be for more than 5 years of usage, which results in bullseye maculopathy. What you want to remember, one more disease, slightly extra edge for INI-CT, just to compile all dystrophies for you. There's something known as Oguchi's disease. Sounds Japanese, and from that only you remember some Japanese phenomenon known as Mizuo Nakamura phenomenon is there. No need to know anything beyond it. It's also known as congenital stationary night blindness. Okay, so this is about the dystrophies. So now talking about retinoblastoma, so how it will present as is a leukocoria. Alright, so this is leukocoria that I'm showing you here. You can also see on the ultrasound there is an intraocular mass. You can see these white spots which indicate that there is calcification. You can also see these calcifications on the CT scan as these white spots. Okay, so this is how retinoblastoma appears. The genetics of RB is very important. So remember, sporadic type are 60% of the RBs, whereas hereditary are the other 40. Out of these 40, 7% are only familial, whereas 33% are non-familial. So these are the numbers. They used to be asked previously, but now not really. Most common inheritance is autosomal dominant because it is via the RB retinoblastoma gene, which is on 13q14. Yeah. What is trilateral RB? Trilateral RB is obviously bilateral retinoblastoma with pinealoblastoma. Okay, so pinealoblastoma is trilateral RB. Other commonly associated tumor is osteosarcoma because it is also related to RB gene mutation, and I'm sure you know the Knudson's two-hit hypothesis, which is related to RB. Okay, most common clinical feature, the patients are going to present most commonly with leukocoria, like we already saw. Apart from that, the second most common presentation could be esotropia. They can present with a squint, which is esotropia, or they could present with glaucoma. So in order of prevalence, leukocoria followed by esotropia followed by glaucoma, and investigation of choice is contrast enhanced MRI. CE MRI is the investigation of choice. Okay. What I'm showing you here is the histopathological appearance. You can see these rosettes with an empty center. So these are true rosettes which are Flexner Wintersteiner rosettes. Alright, so whenever they are empty, they are true rosettes. Whenever they have something in the center, when they are filled, taught you this in radiology lectures, those are your Homer Wright rosettes. Okay, so Homer Wright pseudo rosettes are gonna have neuropil. in the center. Alright, so these are homoryte and they are frequently associated with medulloblastoma and Ewing sarcoma. Alright, so those are homoryte. So these are flex nerve intestina, true rosettes with empty center, seen in retinoblastoma. Now, treatment really is not very important, but just to tell you the chemotherapy regimen, whenever you have bilateral RB, the treatment of choice becomes chemotherapy, or whenever it's unresectable, it's chemotherapy. It's the VEC regimen, which is vincristine, etoposide and carboplatin that is followed. Okay, we have done the BEP regimen for seminoma. Here you remember retinoblastoma is VEC. So this is about all of the questions on RB. Now let's talk about conjunctival pathology. So this is a very, very important question. This is pterygium. Now normally conjunctival pathologies, in fact conjunctivitis will not lead to any sort of visual impairment. In fact, if you've seen a few videos of BTR only have literally recorded with conjunctivitis, because it does bother you but it's not really painful and it doesn't really affect your vision. Okay, but this is the only exception where a conjunctival pathology can affect the vision, because this is gonna come and occlude on the cornea. Even if it doesn't come on the cornea, it will cause astigmatism because it grows on the surface. Okay, so this is pterygium, which is gonna cause vision loss. Alright, so this is a very important spotter. The treatment here is gonna be to excise it. So excision treatment here is gonna be excision plus an autograft that is preferred here. So this is pterygium. NEET 2023 question, they gave you this image. There's a slight issue with the recall, but this is probably what it was. Even if it was not asked, you need to know this is pinguecula. So this is pinguecula, which is a localized overgrowth of the conjunctiva. So pterygium and pinguecula are two cute words that you want to remember. Then in the conjunctiva, you can have either follicles or papilla. How to identify is when you see that they are grey, opalescent, pale, that is follicle. So when they are pale, grey, opalescent, such words, those are follicles. Whereas when you see that they are red or pinkish, that is P for papilla. Where you find follicles, context with toxins or drugs, that is opraclamidine can lead to follicular conjunctivitis. Viral conjunctivitis leads to follicles. COVID-19, in fact, this is a repeat question. They asked you most common ophthalmic manifestation of COVID-19 is acute follicular conjunctivitis, and chlamydia. We will see follicles in trachoma as well. Okay, so this is the list of causes of follicles, whereas papilla could be seen in bacterial conjunctivitis or allergic conjunctivitis. In allergic, you need to know vernal keratoconjunctivitis, also known as spring catara. So here you're going to have young pre-adolescent boys. Adolescent boys, GNA. Pre-adolescent boys, VKC. Alright, so these are two very important specific demographics that you want to know. All buzzwords. You will have ropey eye discharge, you can have cobblestone papilla and Horner Tranter dots, and what you see here, this line is pseudogerotoxin. Alright, so there's a spelling error. This is pseudogerotoxin that you are seeing here. The drug of choice here is going to be olapatadine along with steroids. Okay, so this is all you got to know about VKC. Can get you questions in the exam. Apart from that, foreign body or giant papillary conjunctivitis. Here you will get history of contact lens. So contact lens becomes your buzzword for Pseudomonas, Acanthamoeba and GPC. Giant papillary conjunctivitis. Okay, so this is about papilla and follicle, general concept, important. Now let's go into conjunctivitis. So bacterial conjunctivitis, most common cause, slightly controversial, but Staph aureus is what is usually considered to be the most common. Hyperacute blenorrhea is referred to as gonorrhea conjunctivitis, whereas angular conjunctivitis, the cause is going to be Moraxella. Okay. Now, chlamydia as a cause, remember the serovars will affect. So when we have chlamydia A to C strain, that is trachoma, whereas chlamydia D to K strain will cause either neonatal conjunctivitis or adult inclusion conjunctivitis. So with this, we go to the approach to neonatal conjunctivitis. A neonate presenting with conjunctivitis, 3 DDs, time is what is very important. If baby is presenting in the first day of life, it is likely because of the chemical conjunctivitis. In a lot of countries, they put silver nitrate in the baby's eye, and that can lead to chemical conjunctivitis. It could be because of gonorrhea. If it is 2 to 5 days, fulminant discharge, red eye would be given gonorrhea, 2 to 5 days. Drug of choice is cephalosporins 3rd generation, and this is a repeat question. Typical timeline 5 to 14 days, that is chlamydia with serovar D2K, and the drug of choice is macrolides for chlamydia, like it is for the respiratory system. Here you can also have in fact associated pneumonia in the baby of chlamydia in this timeline. So this is very important. This is given in the question. Okay, so this is 5 to 14 days. When you see this very scary looking appearance, this is hemorrhagic conjunctivitis. So hemorrhagic conjunctivitis is frequently seen with a few viruses whose strains you need to remember. Very important. One is adenovirus type 2. Second is Coxsackie virus A24. and third is enterovirus 70. How I remember this is by writing it again and again, and that's what you do. Coxsackie, A24, Entero 70, and Adeno 2. These are the causes of hemorrhagic conjunctivitis. Alright, these strains have been asked. That's why I'm stressing on it so much. Now talking about trachoma. You do get a lot of questions with PSM integration here. So trachoma has this WHO grading which is known as FISTO. Before I go there, I've taught you this in PSM where I said that this is a water washed disease. Yes, so environmental hygiene, facial cleanliness can help prevent trachoma. So WHO, the staging here is the FISTO grading. So follicular inflammation, intense inflammation, scarring, trichiasis and opacity. That is what is FISTO. So this is how the normal conjunctiva should appear. Here you are going to have follicles. These are known as sago grain follicles. You can have intense inflammation. You can have scarring, which is known as this arts line here. You can have trichiasis. So as I said, normal conjunctivitis is not going to cause vision loss. So far there's going to be no vision loss. But when you have this interned eyelash, that is what is known as trichiasis. Definition can be asked. When an eyelash turns internally, it's going to irritate the cornea and it's going to produce a corneal opacity, which is the cause of visual impairment. So the only thing that you want to do here, the only surgical indication is when you have trichiasis. So this is the famous SAFE strategy. Repeat question. What are the components of SAFE strategy for trachoma? Surgery. For what? For trichiasis. A for antibiotic. Which antibiotic is the drug of choice? Again, chlamydia. So it's macrolide, it's azithral. F for facial cleanliness. E for environmental change. Both of these stem out of the fact that it's a water washed disease. Yeah, so this is about trachoma. Next we go on to glaucoma. So in glaucoma, what you want to remember is it's a triad of findings. Three things have to correlate here. One is intraocular pressure, which may be increased or could be normal. Second, there are visual field changes or visual field effects, and third is there are optic disc changes. So it's a triad of these three findings in glaucoma. All three need not be present. Okay, so now there are two types. One is the angle closure glaucoma and the second one is open angle glaucoma. So first, what is this angle that we are talking about? So for this, you need to know the drainage of the aqueous humor. So this is where the aqueous humor is getting produced from. From this posterior chamber, it enters the anterior chamber like this, and then it enters into this trabecular meshwork where it is absorbed. So this is just like any sort of sewage drainage that you want to remember. So when that drainage pathway gets blocked, you're going to have more pressure. So this is known as open angle glaucoma. The other condition could be when this iris here, or the other condition could be when this iris blocks the outflow tract. You can see how when the iris, you can see how this iris in a mydriasis position, it's going to come anteriorly and it can block this angle. So this is the angle closure glaucoma. Alright, so how to distinguish them clinically is going to be the presentation. So remember, primary open angle glaucoma, primary angle closure glaucoma. Even if it is secondary, it doesn't matter. The presentation remains the same except for the fact that there will be some other cause for it. So in open angle glaucoma, when the sewage drainage is blocked, what's going to happen in POAG is that you will most likely have a patient who is identified on screening. Alright, so here you're going to have an elderly patient who's not really having any acute presentation. The patient is coming to you with going to have gradual progressive loss of vision, which is painless. On the other hand, exact opposite is when angle closure glaucoma happens. You are going to have a presentation where the patient comes to you with acute pain and a red eye. So very red eye, acute pain, and this is the kind of dilated pupil. So this is the mid-dilated pupil that is frequently given to you in the exams. Okay, so the pathophysiology behind this is anytime you are in a dim light, mydriasis is going to happen. With this mydriasis, what happens is a pupil block. So this is what is known as pupil block. Because the angle is obstructed, now you're going to have fluid which is getting collected here. This is known as iris Bombay formation, and after that what you have is this attachment. There is complete fusion here, which is known as PAS, that is known as peripheral anterior synecdoche. Okay, so this is what you want to remember as the pathophysiology. This has been asked a lot of times. So pupil block, iris Bombay and PAS. Now in angle closure, while we're talking about this, you want to remember that there is a triad here. When in doubt, what do you say? You say Vogt. So this is the Vogt triad of angle closure glaucoma, which includes three things. There is glaucum flecken, meaning there is an anterior subcapsular opacity. There is iris atrophy, and there is pigment dispersion of the iris only on the corneal endothelium. If we talk about the anterior chamber, remember that is going to be very shallow, and that is going to be known as the eclipse sign. Repeat question. How do you manage? So remember, in angle closure glaucoma, it's an emergency. First, you want to reduce the intraocular pressure. So the first drug, the first line drugs are AMP. The first drug, if they ask you, is acetazolamide. Second, you give mannitol. So first we are talking about reducing IOP systemically, alright. And P, I give pilocarpine, miotic drug. Remember, mydriatics are obviously contraindicated here. So acetazolamide, mannitol and pilocarpine. Pilocarpine, drug of choice. But if they ask you first, A for acetazolamide. And then you take the patient up for surgery. What surgery? Because the iris is what is the problem. You do a peripheral iridotomy. So this is done via laser. So this is the treatment of choice for angle closure. Whereas in primary open angle glaucoma, the problem is with the sieve, with the drainage. So you do a trabeculoplasty. So frequently a laser, all of these are laser procedures nowadays. This is laser trabeculoplasty or trabeculotomy that is done. Okay. So this is about the treatment. Here first you would rely on the various drugs which I will tell you about, and then you go on for the procedure. Okay. So this is glaucoma in a nutshell. After this we just have images and we have tests that we gotta know. So first what we want to do is we want to measure the intraocular pressure, and that is done via tonometer. Alright, so all of these are your tonometers, different types for IOP measurement. So this is the Shayot's tonometer, which is gonna measure the IOP by indentation. Alright, so this is indentation Shayot's tonometer. The same indentation concept is also used here. This is your self-monitoring or your digital tonometer. Self or digital tonometer, also known as rebound tonometer for self-examination. What you are seeing here is the gold standard. So this is Goldman's applanation tonometer. So the principle here is applanation, gold standard for IOP measurement, Goldman's. You would see this fluorescent light is how you can recognize it. And in fact, if you want to know about the principle that can also be tested, this is the Imbert-Fick law, which says that pressure is equal to force upon area. So we have a fixed area here. So variable force or fixed area, either of them could be given, it means the same thing. So Imbert-Fick law is what is measured here. Then what you are seeing here can be asked as an image-based question. This is a goniometer or goniometry that is used to measure the angle to distinguish angle closure versus open angle. You can also see the visual field effects, as I said. So what is this? Is the Humphreys static visual field analyzer. This can come as an image-based question here. And when we look at the fundus, remember the changes that you're going to see is cupping. The cup to disc ratio becomes more than 0.3. Okay. What about the visual field defects? So here we need to remember this table. The earliest defect is isopter contracture. This is what is a repeat question. The isopter contracture happens first, followed by a paracentral scotoma. Then it becomes sedal. Then it becomes a complete arcuate scotoma. Then it goes down, it becomes a double arcuate. So far it was one-sided. There is altitudinal visual field defect is also what you can remember. Then it becomes a ring or a double arcuate scotoma with a Rowan's nasal step. Finally, central vision is gone, and what persists in the end is the temporal visual field. That's the last to go, which is also a repeat question. So earliest and last. Last is temporal, earliest is overall isopter contracture. Okay, so this is about all of the questions from glaucoma that you can be asked. So now we talk about one of the most important topics, not from ophthalm point of view, but from pharmacology point of view. And you know, you get questions on this in every exam, especially INICT. So this is about anti-glaucoma drugs, alright? So here what we have to know is what is the mechanism of action and what are the adverse effects. That's the most important thing, like everything in pharma. So first of all, what you want to remember here are the mechanisms. So one is decreasing the aqueous production. First, the drugs which decrease the aqueous production, the drugs which increase trabecular outflow, and drugs which increase uveoscleral outflow. Alright, so the drugs which are going to decrease aqueous production are the ones which cause vasoconstriction. So for this, we can either have alpha agonists or beta blockers. Makes sense, right? So beta blockers is something wherein the most commonly used drug is timolol, but the best one is betaxolol. Alright, so these are the beta blockers that we use. The side effect for beta blockers, you want to remember B for blepharospasm. So they can cause blepharospasm and they can reduce the corneal sensation. So corneal hyposthesia or corneal sensation reduction are the two side effects you want to remember here. Then when we come to alpha agonist, you can either have non-selective, that is dipivefrin. Dipivefrin is nothing but the prodrug of epinephrine, and you can have selective alpha-2 agonist, which is apraclonidine and brimonidine. Now the side effects. So dipivefrin, remember, produces black conjunctiva. How you want to remember this? Produces black conjunctiva. How you want to remember this is A, B, C, D. So black conjunctiva, alpha agonist, dipivefrin. Alright, so this is ABCD. Apraclonidine, you want to remember there is lid in the name, apraclonidine lid. So this causes lid or eyelid retraction. Brimonidine starts with BR, brain. So you want to remember this suppresses the brain in infants. Or you can remember, last part kar do, BR, you want to remember breathing. It stops the breathing. Or Brimonidine, BRI, it inhibits breathing. So this causes apnea, and that's why this is not used in children. Okay, so this is what are the side effects of alpha agonist. This is very, very frequently tested. Then we have carbonic anhydrase inhibitors. Like we've seen, these are systemic drugs. So acetazolamide is the first drug that we use in angle closure glaucoma, like I told you. And here you want to remember their side effect is metabolic acidosis. So this is something that I've taught in the renal system as well. You want to remember acidazolamide, not acetazolamide, acidazolamide, and you'll remember that it causes acidosis. Then we have increased trabecular outflow. So what are the drugs which increase the trabecular outflow? One is cholinomimetic drugs, which includes pilocarpine, so cholinergic agonist, and we have a new drug that is Rho kinase inhibitor. Very, very important mechanism wise. So here you want to remember two drugs, pilocarpine and Rho kinase inhibitor, that is netrasodil. So you know in Hindi, netra means eyes. So that's how you can remember netrasodil is for the eyes for glaucoma. Okay. So pilocarpine, what it does is it causes meiosis. Yeah. So for meiosis itself, you want to remember it makes everything small. So it also causes NLD stenosis, nasolacrimal duct stenosis as well. With netrasodil, you want to remember it has a side effect of vortex keratopathy or cornea verticillata. This we have already done with chlorpromazine, right? Antipsychotic drug as well. Okay. So this is about trabecular, and what gets most frequently asked is which is the drug that increases uveoscleral outflow. In fact, this is the drug of choice for primary open angle glaucoma. This is PGF2 alpha analog. So latanoprost and bimatoprost are the drugs which are used here. Their side effects are very, very important. So the side effects that you want to remember, one is heterochromia iridis. So it changes the color of the iris. It causes hypertrichosis. Alright, so eyelashes, eyebrows can increase. This is hypertrichosis, and very important, cystoid macular edema, CME. So these are three side effects of PGF2 analogs that you want to remember. Alright, so these are the anti-glaucoma drugs that we want to remember. Now images on cataract. Alright, so you can be asked images about the different kinds of cataracts. This that you're seeing here looks like a snowflake, isn't it? So this is a snowflake cataract, beautiful cataract, you know, that you're seeing here. This is seen in diabetes mellitus. Remember, the pathophysiology behind cataract and diabetes is because of the sorbitol pathway. Alright, so it's because of the sorbitol pathway. There is cortical cataract. Everywhere else, you know, if you are in doubt, the most common type is posterior subcapsular cataract. Diabetes is one of the places where it is cortical. Okay. Then something very typical, you know, just the image itself tells you that this is oil drop cataract. This we've already seen in biochemistry. This is galactosemia. You see this in galactosemia, and this is because of the accumulation of the compound which is galactitol. Right. So in the metabolism, we have seen galactitol accumulates here, and that is what results in oil drop cataract. What you are seeing here looks like a sunflower. So this is sunflower cataract, which is because of copper deposition. So this can be seen in Wilson's disease, or chalcosis, which is because of any retained foreign body. Alright, we have already talked about Kayser-Fleischer rings and Wilson disease, isn't it? What we have here is like a Christmas tree. So this is the Christmas tree cataract that you have in myotonic dystrophy. In PATH, we will be learning about the trinucleotide repeats. So myotonic dystrophy, remember I've taught you cannot terminate grip. So that is CTG. Alright, so this is Christmas tree cataract, and this is last year NEET question. It's not really a cataract, but I've just placed it here so that you remember it together. This is pseudo exfoliation syndrome. Alright, so this is pseudo exfoliation syndrome, where you have this dandruff-like material here which is deposited, and this is frequently seen in elderly population is what was the question. Alright. So this is what you want to know. As far as the congenital cataract type goes, two names you want to remember. So the most common congenital cataract is the blue dot cataract. Alright, so that is blue dot cataract. However, it does not result in visual impairment. What results in visual impairment is the lamellar cataract. Alright, so lamellar cataract is the one which results in significant visual impairment. Alright, so these two images can be asked to you. Few more named cataracts that you want to know about. One is polychromatic or breadcrumb, and this is a part of complicated cataract when you have any secondary condition complicating and resulting in cataract. Glass blowers cataract is because of infrared radiation. Shield-like cataract seen in atopic dermatitis. So here the images are not very, very important, just the names are important. And in NF2, we have posterior subcapsular. Like I said, when in doubt, you can mark posterior subcapsular cataract. Okay, so these are the types that you have. Now let's talk about surgery. So I'm not going to go into the steps. It's better you learn that from the experts. I'll just tell you the potential questions here. So there are mainly 4 types of cataract surgeries. In the conventional type, which is no longer done, you have a very long incision of around 7 to 8 mm, which is given at the limbus. In SICS small incision, you have your 5 to 7 mm of incision, and what you make here is a sclerocorneal tunnel. Nowadays, what is frequently done is phacoemulsification or the flax procedure. In phacoemulsification, the incision size is 3 to 3.5 millimeters, and what is given here is a clear corneal incision. So the sizes keep subtracting 2. So from 7 you go to 5, from 5 you go to 3, and in flax basically means femto laser assisted cataract surgery. So femto laser is being used. Remember, the kind of laser is ND glass. So this is not ND yak but ND glass laser, which is of 1053 nanometers. Remember, the principle behind both of these, phacoemulsification and flax, is photodisruption. Alright, so photodisruption is the mechanism wherein we are going to be using these piezoelectric crystals. They're the same as the ones we use in ultrasound, okay, wherein we pass electrical energy, they are going to vibrate and produce mechanical energy. Alright, so that is photodisruption. We use these crystals which are vibrating at 40 kilohertz. Okay, so this is what you want to remember here. Coming on to the complications, that is where bulk of the questions come from. But before that, you just want to know these two images. This has come as an image-based question. When you have this S-shaped structure, you can identify it as anterior chamber IOL. When you have this round, you can identify as posterior chamber IOL. So this can come, and the formulae will depend on the axial length. So you have these various formulae, Holiday, Hoffer, and SRK. The one which has been tested probably in INI-CT because it's very tough is myopic laser. What is the formula? That is Haigis L. So that's just one thing that you can remember, not very important. Okay, coming on to the important stuff, that is complications. Okay, so the most threatened, deadliest complication is endophthalmitis. The most common cause in an early onset endophthalmitis is epidermidis, whereas in late onset it is Propionibacterium acnes. So this is something which is very, very fulminant that you want to prevent. Most common delayed complication that you want to remember is posterior capsular opacification. That could be in two forms. This image-based question has come earlier. This is Elschnick's pearls. The other one could be Sommering's rings. Okay. So these are two things that you want to remember when you see something pearly like this. These are Elschnick pearls. Okay, so these are the complications. I've already talked about Irwin-Gass syndrome, which is also delayed complication wherein you have cystoid macular edema. Right, so you want to remember Irwin-Gass as well. Okay, so this is about cataract. Now going on to the changes after trauma, very, very important. So these are all after blunt trauma, all of these images. So what you're seeing here is known as the Vossius ring, which is nothing but the iris pigment getting deposited here. So that's Vossius ring. Very important image. This is known as iridodialysis, wherein you have a break in the iris. What you're seeing here is iris prolapse. Okay, so very, very important to distinguish these two images. In fact, iris prolapse could be a complication of cataract surgery as well. Okay, so all of these could be surgical complications as well. What you're seeing here is a cataract which is a result of trauma. So this is your rosette or stellate cataract which happens after trauma. And what you're seeing here is blood in the interior chamber. So this is hyphema. Okay, so these are the complications of blunt trauma. A lot of questions come in penetrating and perforating trauma. In the eye, whenever ciliary body is injured, what will result is a bilateral, not just in the affected eye, but bilateral granulomatous panuveitis, and this is known as sympathetic ophthalmia. So remember, sympathetic ophthalmia, what is going to result is this granulomatous panuveitis bilaterally. Alright, so this is very, very important that you want to remember. So how you prevent it and how you treat it, extremely important. So the prevention is by enucleation. You want to enucleate the affected eye, whereas once it occurs, how you treat it is by steroids. Alright, so once the enucleation of the affected eye is done within 14 days of the trauma, this would probably not occur. But if that does not happen, you're going to have granulomatous panuveitis, in which case then the treatment becomes steroids. So read the question very carefully here so as to understand what is being asked and what you should mark. Okay, so this is about sympathetic ophthalmia. In the recent times, you've always gotten one question from this. So if you see I've not included uvea here in the discussion, because you only get two questions and those are on panuveitis. So you want to remember panuveitis you will hear in two conditions. One I've already taught you, which is sympathetic ophthalmia. Another would be Vogt-Kanayagi-Harada syndrome. Alright, so very scary looking name. Just remember the name here. That is also a condition where you have panuveitis and you're also going to have skin changes here. Okay, so skin changes you can also have. You can also have associated vision and hearing loss. Alright, so different systems can be affected. So just remember these two things for uvea per se. Going on to probably the toughest chapter ever, which is squint. But before squint, the questions that you actually get are based on the anatomy of the extraocular muscle, are actually on the actions of the extraocular muscles, and that is what we gotta remember. So these are the extraocular muscles, which I'm sure you've heard. So now, what is the nerve supply and then what are the actions? So nerve supply, I'm sure you all know LR6, SO4. So LR is 6th cranial nerve and SO is 4th cranial nerve. Everywhere else it is the 3rd cranial nerve. Yeah, so this is sorted. Coming to the primary action, it's the easiest for these two muscles which have no other action. So medial rectus is going to do what? It's going to adduct. Yeah, very easy. There's lateral rectus is going to abduct. So far so good. Now you're going to have 3 sets of actions: primary action, secondary action, tertiary action. So here what you want to remember is one mnemonic which will help you is SIN, RAD. Okay, which means anything which has the name S in it, superior in it, is going to intort, intorsion, rolling of the eyeball inwards, and any word which has recti is going to adduct. So these are going to be the tertiary actions, alright. So adduction, abduction, because MR, LR are taking care of it, they're only going to be tertiary. So can I just write that? Both of these recti, rad, so these are adductors, yeah, adduction is the tertiary action, whereas both the obliques are going to be abductors, alright. So this is sorted already. So one step is done. Now coming to the recti. So superior and inferior recti, they are going to have the primary action as elevation and depression. So superior rectus obviously is going to elevate. So there's going to be elevation. There's inferior rectus is a depressor. Easy enough. The secondary action is going to be intorsion, extorsion. So because SIN, so this is intorsion, whereas IR is extorsion. So this is how you do it step by step. Obliques are going to be ulta. Oblique means they have an action which is opposite to their name. So their primary action is intorsion, extorsion, and their secondary action is going to be elevation, depression, right? So because their name is going to be ulta from their action or opposite from their action, superior oblique, remember, is going to be, which about your superior oblique, remember, is going to be a depressor, whereas inferior oblique is going to be an elevator. Alright. On the other hand, superior oblique, SIN, so this is an intorsion, this is the primary action, and inferior oblique is an extorter. Alright. So step by step, this is how you remember this very scary looking table otherwise. Okay. So this is sorted. Now let's talk about few laws here. So there is Herring's law and then there is Sherrington's law. Herring's law says that there is equal innervation. Herring's is equal innervation to the yoke muscles. Now what are the yoke muscles? These are muscles which do conjugate gaze. Alright, so basically let's say I want to look towards this side, both of the medial rectus, lateral rectus have to function together and they should get the same supply at the same time, isn't it? So what are all the yoke muscles? So obviously just do the opposite of the name and it becomes very easy. So medial and lateral rectus go together. Then anytime you have IO, do the opposite. I ki jagah will be S and O ki jagah will be R. Alright, so similarly, so that's how you know IO and SR. Similarly, so this is how you can understand the yoke muscles. It's going to be the exact opposite. Okay, so this is about the yoke muscles. They get equal innervation. What is the law of Sherrington? Sherrington is the law of reciprocal innervation, meaning the antagonist muscles have to be suppressed. For example, if the medial rectus of this eye is working, the lateral rectus of the same eye needs to be suppressed. Alright, so this is for the same eye basically, whereas yoke muscles are for both eyes. Okay, so this is what we want to learn here. Then talking about squint definitions. So anytime I say ESO means is inwards, alright, it's inward displacement. So that is ESO. Remember, two conditions which cause esotropia or esophoria, I'll tell you what they mean, are very, very important. So one is hypermetropia. The second one which I already taught is retinoblastoma. Yeah, so retinoblastoma, we have seen the second most common manifestation is esotropia. Okay, so this is about the esotropia. Exotropia means outward deviation, and obviously this would be with myopia, association with myopia. Hyper and hypo, very important. Hyper means upwards. Whenever you are hyper, your energy is higher. So you remember upwards deviation of the eye, whereas hypo is downwards displacement of the eye. Phoria means latent squint, whereas tropia means manifest squint. Alright, so whenever I say esotropia, it is manifest squint. Whenever I say esophoria, it is latent squint. Alright, so that is what is very important. Then one of the repeat questions, do not go into the depths of it, just remember that secondary deviation is more than primary deviation. This is a manifestation of paralytic squint, whereas when both are equal, primary and secondary, that is a non-paralytic squint. So these are the terms that you want to remember here. Okay, so these are the terms with squint, and if you do this, half of your job is already done. Now, recognizing. So in the recent years, you get almost every year one of the questions from one of these sets. Now, when somebody shows me such entire gaze picture, I'm going to be scared and I might leave the question thinking I have not done squint. But all you got to do is see the central position. What do you see? I see there is ptosis of this left eye, and I see that there is ptosis of this eye and the pupil is down and out. The moment you see these buzzwords, ptosis with down and out pupil, I know for a fact that this has to be third cranial nerve palsy. That's all. I don't even have to look at the others, you know. So this is how you crack these questions. Anytime you see one eye is upwards, which is which is your hypertropia, or you see that they're giving you head tilt. The moment you see head tilt, that is your clincher, that you are being shown trochlear nerve, superior oblique palsy. So this is your fourth cranial nerve, SO palsy. And anytime abduction, adduction is a problem, you can see how this eye is adducted. If the person cannot abduct it, means there is lateral rectus palsy. So this is lateral rectus palsy of this eye, which is sixth cranial nerve. So this is how you crack the cranial nerve palsy. Ptosis and down and out is third. The moment you see head tilt being mentioned, it is fourth, and the moment you see lateral rectus, it is sixth. Alright, so this is about cranial nerve. Now the difficult AIMS question, which makes PARC 3-step test important, and something which a few of you might just want to skip to the next topic already. So just bear with me for 5 minutes and I'm going to make this very, very easy. So all you got to do is remember 2 metro stations. Alright, so in Delhi we have 2 metro stations. One is IGI, which is Indira Gandhi International Airport, and then you have ITO. Okay, so if you remember these 2 stations, then PARC 3-step test is done. So what you want to remember here is start I for ipsilateral. So ipsilateral gaze tells you inferior, and ipsilateral tilt tells you oblique. Okay, so just remember these 2 phrases, IGI and ITO. Alright, so ipsilateral gaze tells you about inferior muscle being involved, ipsilateral tilt tells you about oblique muscle. So now how do we approach? So in the exam they're going to tell you that this patient who has left hypertropia that increases on right tilt and right gaze, what is the muscle which is involved? Okay, so anytime you start off with hypertropia only, alright, you can't start with hypo, you start with hypertropia. So here it's already left hypertropia. So now tilt, ITO, so ipsilateral tilt is oblique. So here you have contralateral tilt, it increases on right tilt. So this becomes what? It is not oblique. So this tells me that I'm dealing with a rectus muscle palsy. And right gaze, so again contralateral gaze, so this tells me that I'm dealing with superior. So I have already localized the muscle, superior rectus. Now right superior rectus or left superior rectus? For that, look at this. So superior rectus elevates. So now when it was left superior rectus palsy, would it ever lead to left hypertropia? No. So that is how I know that this is right superior rectus, because the function of the left superior rectus is going to be to elevate, and that wouldn't result in hypertropia. So this is how I know the answer as right superior rectus. Let's do it one more time. So now the examiner has given me right hypertropia. I can't function with right hypertropia. My mnemonic falls flat. So I convert it to opposite. If it is right hypo, means it is left hypo. Yeah. So this is left hypertropia. That is how I look at it. Left hypertropia increases on left tilt. ITO, so this is definitely oblique that I'm dealing with. Right gaze, so this is contralateral gaze, so I can localize it to superior. So the muscle I'm dealing with is superior oblique. Now superior oblique, this is opposite, isn't it? So superior oblique isn't an elevator, it's a depressor. So when the depressor is not working, I will have hypertropia. So this is left superior oblique. Because the depression is not happening on left side, there is left hypertropia. So this is how you deal with it. So what is my tip? Just write down IGI, ITO, see the question and match. Alright, just create these sets of scenarios and go about solving. This is just like maths, very, very easy. Okay, so this is PARC 3-step test. Going on to other tests of squint. So here you want to know about cover, uncover in detail. So remember, cover test is for tropia, meaning this is for manifest squint. So what we do is we cover the normal eye. So here we cover the normal eye and the eye moves. That is a sign of manifest squint. On the other hand, for exophoria, meaning for latent squint, we are going to cover both the eyes one after the other because we don't know which eye is the squint. So the abnormal eye is going to drift when covered. So whenever I uncover, it is going to move. Alright, so whichever eye moves on being uncovered, that is the eye which is actually having the phoria, which is the latent squint. So this is the cover uncover test. Takeaway is cover test is for diseased manifest squint. Alright, so that is how you remember. Anytime you have some disease, you want to cover that disease, right? So that's what we are doing, but we are covering the normal eye, remember that. The next image came as an image-based question in last year NEET. So what you are seeing here is Maddox rod. Alright, so this is Maddox rod that we are seeing. This one here is known as Worth 4-spot test. Just remember the name. This is the prism bar test. What you want to remember with prism bar is that the base is opposite to the side of deviation. Okay, so the base is going to be opposite to the deviation. What you are seeing here is the Hess chart. Don't confuse this for the Amsel's grid. This is the Hess chart for testing diplopia. Okay, so these are the instruments for squints that you want to remember. Finally, last 2 slides on some high tables and images which are miscellaneous. So the definition of enucleation, evisceration and exenteration. Enucleation is when you remove the eyeball plus the optic nerve. Alright, so this is enucleation. This is done in context of retinoblastoma, sympathetic ophthalmia like I already told you, or any penetrating trauma basically. Yeah, so more or less same thing. In trauma, this is what is done, enucleation. Evisceration is when you leave the sclera. Sclera is left behind, and this is for endophthalmitis. Yes, this is for endophthalmitis. Alright, so endophthalmitis, the sclera is not involved, so that is left behind. Whereas in exenteration, everything is removed. All of the orbital contents are removed. This is done for two M's, mucormycosis and metastasis. Alright, so mucor and metastasis. You must have seen patients after the pandemic with mucor, who've undergone exenteration. Okay, so remember, E viscera, only the viscera of the eye is removed. Enucleation, N for optic nerve and eyeball are removed. Exenteration completely for mucor and mets. Okay, so this is about the procedures, which are pretty confusing. Next confusing thing are the side effects of topical steroids versus systemic steroids. So topical steroids lead to an increased intraocular pressure, this is glaucoma, whereas systemic steroids lead to cataract. A very easy mnemonic for this is GTCS. So glaucoma in topical, systemic cataract. Okay. Topiramate is a repeat question. It leads to secondary open angle glaucoma. Alright, so topiramate leads to glaucoma again. Then, how do you localize to different compartments? So far I've taught you all of the images, but if the clinical scenario is given, that's also going to help you localize to the compartment. So anytime you have gradual, progressive, painless diminution of vision, always consider cataract, and something I already told you, primary open angle glaucoma. So this is going to be painless, gradually progressive diminution of vision. If you have a sudden painful red eye with diminution of vision, one very important is primary angle closure glaucoma, and the second one is going to be uveitis. Sudden painless diminution of vision means it's localized to the posterior segment of the eye, retina or the vitreous. Floaters is vitreous. Alright, so this is vitreous hemorrhage where you frequently get floaters, and metamorphia, distorted sort of vision, Amsler's grid. This is for macular pathologies. Okay, so this is how you can localize depending on the symptom complex. Eye drop, so this is an AIMS question, so remember eye drop is to be put first followed by ointment. It's never the ointment before eye drops, and frequently ointment is given as an HS, which is before bedtime prescription. Okay, for congenital ptosis, a very difficult topic as such. Two questions have only been asked again and again. One is, what is the surgery you would do if LPS function is poor? You would be doing a frontalis sling procedure, and if LPS is good function, you want to do an LPS resection. Alright, so these are two procedures that you want to remember which have been asked. Talking about Snellen's chart and visual acuity, so here the questions have come from what is the distance from the chart where you're standing. I'm sure you know this. This is 6 meters, and that happens to be the nodal point of the eye, and the minimum angle of resolution that every letter subtends here is 5 minutes of arc. Alright, you want to remember 5 minutes of arc here. So the topmost letter, AIMS question, how much angle does the topmost letter do? So basically what you want to do is, whatever is the division of the two, you just multiply that with 5. So 60 by 6 is 10, so this becomes 50 minutes. If it is 6 by 6, simple, 5 minutes. So you just do the division, and whatever is the result, multiply that with 5. That is how this is to be done. This image-based question has come when you have an extra layer of eyelashes. This is what is known as distichiasis. One more question, you already know what is trichiasis. One more question could be tylosis. So tylosis is the thickening and hypertrophy of the eyelid margin. Okay, so this is about the two pathologies here. Finally, few image-based questions which could be tested. What you are seeing here is an eyelid coloboma. When this eyelid is not fused here, you could have an iris coloboma or other layers as well. What this would result in is exposure keratitis. Okay, so the side effect of this is going to be exposure keratitis. What you are seeing here is the lens having a curve. This is anterior lenticonus. So remember the syndromes associated with lenticonus. Anterior lenticonus is associated with Alport syndrome, whereas posterior lenticonus syndrome is associated with Lowe syndrome. Lowe syndrome is oculocerebrorenal syndrome. So if you just know this much, the systems and everything get sorted. What you are seeing here in this image is ectopia lentis, very, very important. So ectopia lentis, you need to know the causes here. So Marfan syndrome, then you have homocystinemia or hyperhomocystinemia, where homocysteine levels are raised. This we have done in biochemistry as well. And one syndrome is Weil-Marchesani syndrome. So I'm going to tell you the clues which will help you identify amongst these. So Marfan's, I'm sure you know, have Marfanoid habitus. Yeah. So here the kind of deviation is going to be fan outwards. Yeah. So this is going to be superotemporal. Okay. So just like fan, it is superior temporal. Homocystinuria. So this is inferonasal deviation. Here you would have associated marfanoid habitus. So just don't go by the long limbs and height. It could be a feature of homocystinuria as well. And one more feature that you want to remember here is the presence of accelerated atherosclerosis. Okay. So homocystinuria could be a result of either B6, B9 or B12 deficiency. 6, 9, 12 could result in this, or beta cystathione synthase, which blocks homocysteine to cysteine metabolism. Okay. Weil-Marchesani syndrome, what they're going to mention is microspherophakia. So microspherophakia would be mentioned. In addition, brachydactyly, short fingers, can also be given here. Alright, so these are the three syndromes that you want to remember with ectopia lentis. Very, very important image-based question has been asked a lot in the recent exams. What this is congenital ophthalmos. Alright, so you're going to have this blue colored eye. This is ophthalmos is what you want to remember. Here you have a triad of blepharospasm. You have a triad of blepharospasm, photophobia and lacrimation. So BPL, the triad is for ophthalmos. And what you see here is a chalazion. What is chalazion? Which gland it affects is what you want to know. So this is the meibomian gland which is affected. There is chronic lipogranulomatous involvement. It is frequently painless. This is in contrast to stye or external hordeolum, which is painful. If you've ever had a stye, you know it is much painful. Alright, so this is about the chalazion. So this takes care of ophthal, one of the most dreaded things for me, at least for teaching, and this is one of the final recordings that I'm doing. I saved it for the last, but I hope I've made it